Good evening, friends. I'm Dr. Kaladhar from Yashoda Hospitals. Welcome to our Tuesday masterclass from the Department of Critical Care Medicine, Yashoda Hospitals. We bring forth these sessions almost more than 3 years, where the students come in and present the live cases from their ICU, and the expert examiners will be there on board, discussing this case as we go through, as it happens in exams. So most of the students, we have a YouTube link, Yashoda Masterclass. If you click, all the previous classes will be able to see them. So access them. So here, most of the students had given their feedback that these sessions are especially helpful because all experts come on board where they share their decades of experience and expertise, which translates theoretical knowledge into practical applications. Very, very helpful. Even the intensivists from remote places like second-tier cities and all, they had given feedback that the sessions are very helpful even during their practice in ICUs. So for this, today we have a class on meningoencephalitis. I invite to our expert examiners, Dr.Ashith Hegde, sir. Sir is head of the Department of Critical Care at PD in Hinduja Hospital from Mumbai. He is having decades of experience, very well, had seen his lectures, very simplified and very well received, gained knowledge through his lectures. Thank you, sir, for coming on board. I welcome you, sir.
Thank you.
Yeah, I welcome Dr. Swagata Tripathy, ma'am. She's a professor and in charge of ICU from AIIMS, Bhubaneshwar, having a vast experience across critical care. Thank you very much, ma'am, for coming on board. I welcome you.
Thank you.
So today's topic is on meningoencephalitis. This is a very, I can say, emergency neurological conditions where the approach has to be swift in diagnosing these patients and treating. Otherwise, sometimes we lose these patients where they present in severe critical condition. We see these patients across different spectrums of ages and sexes. So very important as a critical care physician discussing these emergency neurological conditions. To present this case, we have two of our students from Care Hospitals, Banjara Hills, Hyderabad, Dr. Imran and Dr. Likhitha. So they both will present the case which they are dealing with in their ICU. So as we go through, the madam and sir will pitch in and ask the questions. Thank you, sir. Thank you, madam. Dr. Imran and Dr. Likhitha, please go ahead and start your presentation.
So, good evening, one and all. So, you'll be next page. So, we had a 57-year-old male patient came with the chief complaints of frothy discharge from mouth with involuntary jerky movements and decreased responsiveness since 2 hours. So, after coming to the emergency department with involuntary movements of limbs with frothy discharge and decreased responsiveness and tongue bite since 2 hours with no bladder and bowel incontinence, and there was a history of generalized weakness since 1 day, no history of nausea, vomiting or headache, no history of visual disturbances. Next page.
Is tongue bite always standard for a seizure?
No, sir.
Diagnostic of seizure? Suppose he had come to you after seizure gone away. Here, of course, he clearly has a seizure, but suppose he came to you with some loss of consciousness and tongue bite.
Yeah, sir. It definitely, we can think of GTC as
Or is it always definitely a seizure?
Always not, sir, but there is other.
Or tongue bite is definitely a seizure. Any particular tongue bite is always a seizure.
Generalized tonic-clonic seizures, they
No,
will
tongue
be
bite.
tongue bites.
Forget about the tonic-clonic. I'm talking about here. He's coming in front of you with seizure. But suppose somebody said he lost consciousness at home, and there was a tongue bite. Suppose the front of his tongue was bitten, and one patient front of the tongue is bitten, the other patient side of the tongue is bitten.
Yes.
Which of the two has definitely had a seizure, or neither of them, or any of them?
Side of the tongue will be more specific, sir. Side of the tongue.
Yeah, side of the tongue bitten is almost certainly a seizure. Front of the tongue you can get even with syncope.
Yes.
But if the side of the tongue is bitten, almost certainly a seizure. Okay. So tongue bite is a fairly good sign, provided the side of the tongue. Front of the tongue can be bitten in either syncope or seizure. Doesn't mean anything. But side, this patient of course actively convulsing. There's no doubt. But sometimes people just come with transient loss of consciousness and tongue bite. So if it's the side of the tongue, it's almost certainly a seizure. Fine.
There were no history of ear pain or any ear discharge, no history of any rash, no history of any travel, or no history of any animal bite or contact. And in the past history, patient was hypertensive on tablets linidipine 10 mg BD and tablet clonidine 0.1 mg BD, and he was type 2 diabetes on tablet linagliptin 5 mg and insulin mixtard 15 units and 10 units and 15 units, and even known case of chronic kidney disease on maintenance hemodialysis 3 by 7 since last
A
2
small
years.
point, if it's on pneumonia, you call it end-stage renal disease, not CKD.
Yes,
Okay.
and there was no significant surgical history. Next.
I'll just stop over here. Dr. Likhitha and Dr. Imran, if you were not presenting this case as a case of meningoencephalitis, would there have been any other negative history you would have elicited from what you just said to rule out some other more common causes of seizures that come to the casualty?
Yes, ma'am. The normal causes of the seizures, other DDs was infectious causes and non-infectious causes. We wanted to divide it. Infectious causes is probably any meningitis, encephalitis, and any systemic infections.
Just don't tell me the causes. Tell me what history you would have taken to rule
Yeah.
out.
Any focal neurological deficit which we can think of any stroke, ma'am, acute
Any-
ischemic stroke or an hemorrhagic stroke.
Any deviation of the mouth or
More
patient.
common than that? More common than that? You're talking about
Because ma'am, diabetic patient, any the skippage of dose or increased dose without intake of the food can be possibility of hypoglycemic seizures, ma'am.
without history and hypoglycemia. Anything else?
As he is a known hypertension, he can be having any accelerated hypertension which can cause seizures, hypertensive patients also.
He's asking about history. What all things would you ask about history? Like you said, one is
Like-
about course of insulin going up or down.
Like when was the last RRT like dialysis was done, ma'am?
Yes.
So based on that, if
You have to ask about the regularity of dialysis and electrolytes as well, right? Hyponatremia.
Hypocalcemia.
they are more prone for hyponatremia, hypocalcemia, and
So how, because these patients will usually have their investigations. So
Yes.
it should say that there has not been anything weird going on in their electrolytes. The dialysis has been going on well, and there is nothing, significant in that history. Because those are the commonest and easiest to handle. Please go
Yes.
on.
So there was no significant family history of any like stroke, known case of stroke or any fever. And in personal history, patient was a vegetarian, regular bowel and bladder movements, and there was no history of smoking or any alcohol consumption, and no history of any drug abuse, and not a known case of any allergies. Next. And in general physical examination, patient didn't had any pallor or any cyanosis. There was no clubbing, no icterus, no lymphadenopathy. Bilateral pedal edema was present. Vital signs on examination, so temperature was 98 degrees Fahrenheit. Heart rate was 112 beat per minute. Respiratory rate 23 cycles per minute. Blood pressure was 160 by 100 mm of Hg on right upper limb, and saturation was 98 on room air. Patient was well built and nourished.
This is when he was convulsing.
No, sir. At ER vitals, when he came to ER, these are the ER vitals.
And in neurological examination, patient was drowsy but arousable, and his GCS was E3V2M5. There was no facial deviation. Symmetry was intact. Pupil bilaterally equal 2 to 3 mm reactive. There was no focal neurological deficit. Tone was normal. There was generalized hyporeflexia.
When would you consider intubation in these patients with a seizure?
The patient's airway is, as the patient is drowsy, but he's arousable and obeying trying to obey commands. And his airway is protective, so we and saturations are maintaining, so we didn't consider of intubation, sir.
The threshold for intubating a seizure patient is higher or lower?
Higher, sir, because chances of aspiration, drowsiness.
No, threshold higher means you would intubate them early, or
Lower, sir, like
you would intubate them early, a seizure patient.
Early.
No, what I meant is at the same level of GCA, somebody who's had a stroke and somebody who's had a seizure. Which one would you think of intubating?
Stroke, like stroke patient, sir.
Why not seizure? Why not?
Like it is a reversible
Yeah, so
cause,
they
sir.
might recover. So sometimes, if you just wait a little, just give them head on the side, etc., they might. Of course, you have to prevent aspiration. I'm not denying that, but sometimes these people recover pretty quickly. So your threshold has to be a little lower. You don't have to jump to intubation like for a traumatic brain injury or stroke, etc., where generally a GC is less than 8 or unable to predict the airway. You'd intubate fairly. You wouldn't waste time. But in a seizure, maybe you can afford to wait. You don't have to jump to intubation because sometimes they recover, no? So you obviously keep them in the proper position and all that, and you try and protect the airway, but the threshold has to be slightly higher. You don't jump to intubation, see, unless of course, when do you otherwise intubate patient with the seizures?
Like patient is having any status
Unless
epilepticus.
GCS is not improving, of course. What else?
Yes, sir. Patient is having persistent seizures for almost more than.
So when you're going to treat them with the anesthetic agents, of course, you might have to protect the airway. That's a different. When you're going to start midazolam or propofol or whatever that, there you generally have to protect the airway, no? Even if they have resistant refractory seizures, then you're going to start a.
Yes, sir.
Infusion for the
Anesthetic agents to maintain, sir.
ठीक.
To with them. And in systemic examination, sir, pulmonary system, there was no respiratory distress. There was bilateral air entry was present. There was no added sounds. In cardiovascular system, S1, S2 was present. No audible murmurs or and it was sinus rhythm. In abdomen was soft, non-distended, non-tender, no organomegaly. Bowel sounds were present. Next. So, as of now, our differentials were we were thinking patient is a known CKD. So initially we thought for metabolic causes, ma'am, like any uremic seizures could be the possibility, or patient might be having any hypoglycemia. But here in our evaluation, sugars were normal, so could be some hypocalcemia. So mainly initially we ruled out all the metabolic causes. So in this, on evaluation, we found to have that there was raised urea for this patient, almost 227 with hyperkalemia with metabolic acidosis.
But he was being dialyzed regularly.
due for dialysis.
He was due for dialysis, sir, this patient, so he came.
So, did you look at his how his trends for the urea were doing? Because many of them have a baseline urea of even 117 between dialysis as well. So, what was happening to his pre-dialysis and post-dialysis urea before this? Did he have his previous investigations?
In previous ma'am, like normally his urea was between 112 to 130, in that kind of range it was, ma'am. But here it was 227 in this case. So
one more question here. When you suspect uremic related seizures in a patient who's come to ICU, who's come to ER, who's not really missed an episode of dialysis. Okay. So he was somebody who was on a regular hemodialysis, going very sincerely, but now he has come with a jump of urea. What other things will you think of? It was not expected that it will go to 220, right? But it has.
So, we have to rule out what are the other causes. Any GI bleed causing increase in urea levels, or any medications patient on steroids, increasing the urea levels, ma'am, or any infection causing elevated urea levels. We have to see that.
Okay, so again, the point is the history of previous dialysis. What was happening there is very important.
Yes.
Go on.
Next slide.
Other thing is somebody maintaining dialysis comes with neurological problem. What is the other thing you need to worry about? On regular dialysis, what complication of dialysis can happen, causing them to come with conversion? Other than your chronic dialysis, what other complication of dialysis can happen?
Normally, regular dialysis, you want to say, sir, long-term
They
dialysis.
come with regular dialysis, come suddenly with some CNS problem.
We have to say,
Huh?
any Normally, hypoglycemia is
Hypoglycemia
very,
is high.
like, normally we see
Complication of
hypoglycemia.
dialysis, I'm saying. What complication of dialysis?
Excess.
You can get subdurals and all that. Of course, initially you get dialysis disequilibrium, but that is when you start dialysis. But later on, one thing you need to worry about is subdural, because sometimes they use anticoagulants, the dose is more than what they need because they're not cleared clearly. So subdural is quite something that you always need to rule out in somebody, or a bleed, of course, also, but even subdural. Commonly subdural, but could be any bleed. It could be.
So in the initial management, like we have seen,
Question here. How was he getting his dialysis? What was his route?
like left AV fistula was there, ma'am. Left hand upper limb AV fistula.
Inspection, you need to mention about the status of the fistula.
Yes.
How you were giving the history. Right?
Yes.
An examination, no? So the fistula
Yeah.
arm is okay, not inflamed, and it's all right.
So, like we have seen for airway, ma'am, airway was patent. So there was no indrawing of usage of any accessory muscles or anything. And in breathing, patient was like breathing a normal respiratory rate of 16 to 18, and there was no like shallow breathing. It was clear, and circulation hemodynamics were like maintaining them without any support, 160 by 100. And then we have secured a 18 gauge cannula, and initial loading dose of anti-epileptic was given, ma'am. Injection levetiracetam 3 gram stat dose was given, and ABG was done, which was showing pH of 7.39 and PCO2 of 22 with the bicarb of 13, ma'am. It was a normal anion gap.
How do you interpret this?
Like it was a normal anion gap metabolic acidosis.
Normal anion gap metabolic acidosis. What is the pH? What is it?
7.39.
So that's acidotic or alkalotic?
Acidotic. Less than 7.4 is acidotic. So
7.4. Okay. Also, look, normal anion gap is debatable, because normal anion gap is, you don't have the chloride, no? So you can't even talk about anion gap. It's pure metabolic acidosis, you're saying. The pH is almost towards normal, no? So
patient was having like metabolic acidosis with mild respiratory alkalosis also there.
Yeah, because the pH is almost towards normal. And don't talk about anion gap. You don't have a chloride level, no? You can't talk about normal anion gap. How do you know normal anion gap? You don't know. And in uremia, what do you expect? Normal anion gap or high anion gap?
It will be high anion gaps.
Normally, you would expect high anion gap, no?
Yes.
Suppose anion gap had been normal, what were the likely causes?
Like one thing is like any GI losses, like a patient is having chronic diarrhea,
vomitings.
Vomiting.
Hyperkalemic.
Or alkalosis. Vomiting causes acidosis or alkalosis?
Alkalosis, sir, initially.
Don't say vomiting, please. Huh? Why do you get alkalosis in vomiting?
Loss of chloride. H
Yeah,
plus
so chloride.
H plus ions.
You get alkalosis, huh? Okay. So GI, when you put nitric acid, you get alkalosis, no? You don't get acidosis. Plus there is volume depletion, secondary, whatever. Ultimately, vomiting causes alkalosis and diarrhea causes acidosis. Okay.
And blood samples were sent, sir, for investigation, like routine investigation, complete blood picture, renal profile, and LFT with a coagulation profile was sent, sir. And even we have taken blood culture and urine cultures, sir.
Right. So when you get this ABG, how does your differential diagnosis change? And what else would have helped you? Like, I think that has already been said. You needed a sodium and a potassium chloride. Sodium, you've done a glucose, so it's not because of hypoglycemia. You wanted to see the sodium levels.
Yes.
Acute presentation. But you were thinking uremia. Now this is your ABG. Do you think this really matches with the cause of the seizure, your primary diagnosis? When you do an ABG, you have a first diagnosis, you're trying to go towards it.
Yes.
The tests you're sending. Does this take you towards your first differential diagnosis?
Like any other metabolic thing, like hyponatremia, we will be ruling out, maybe if we send renal profile, serum electrolytes if we are sending. hyponatremia to see.
Hypocalcemia is also most
Hypocalcemia.
probably in CKD patients. So in ABG we can see, and we also send the serum calcium levels, which was normal. 8.1 is the serum calcium. So we excluded that cause. And
So what I'm trying to say is, when you're presenting a case, present all this. You have to say all this, that we also looked at this. Therefore, we ruled out those causes and we moved on. Okay.
How do you interpret serum calcium in somebody with CKD? You include only serum calcium level or anything else? CKD patients are likely to be protein malnourished, na? So serum calcium in isolation is enough.
We have to corrected calcium. We have to
Albumin levels, because of course you're saying this was 8, so even if albumin had been low, it is okay. But otherwise, you always look at corrected for the albumin level. Na? Many of these patients might have nephrotic syndrome, hypoalbuminemia, whatever. So always look at it. And sick patients generally have in the ICU have low albumin. So you always look at ionized calcium or correct the calcium for the albumin levels. No? You know the formula, no, for correction of that.
Yes, in our ABG we are having even ionized calcium value also we use.
Fine, ABG, fine, you're right. So otherwise, if they ask you, they might ask you for the formula for correction. So you need to know the formula, no, for correction of calcium for albumin.
We know
4 minus patient albumin levels plus 0.8 into serum calcium levels.
0.8 for every drop in albumin below 3.5. So there is a correction value for
Correction
calcium.
value will calculate.
EEG was also done, sir, which was showing grade 2 encephalopathy. Next.
Why did you send cultures?
Like this is a CKD patient. He is in and out of hospital regularly. So just we wanted to rule out any possibility of any infection.
Was there any other history suggestive of an infection?
Like patient was having a history of fever, ma'am. It was 1 week back, but right now he didn't had any fever episode or anything.
Didn't tell that in the history. It's very significant, isn't it? So only one, like, okay, we'll leave that, but there was some fever that led you to think of
Yes, any infection. So like initially we have started on injection cephalosporin sulbactam 1.5 gram BD, and even suspecting we wanted to rule out any stroke or any bleed. We had done CT brain also, which showed diffuse brain parenchymal atrophy with mild dilation of ventricles, ill-defined hypodensities in periventricular white matter, and bilateral frontal and parietal lobes. Screening echo was done, which was showing good LV function, no RWM, and grade 1 LV diastolic dysfunction. Then patient was shifted to MICU for further management. Next slide. Yeah. So initial blood investigation was done, in which hemoglobin was 11 gram per deciliter, TLC was 15,900, and serum potassium was 6.5, and renal function test was urea was 239, and creatinine was 14.24, and serum calcium was 8.4. So in view of metabolic acidosis and azotemia with hyperkalemia, we have initiated on RRT. So then post-dialysis, patient sensorium was not improved, and all the metabolic causes were seen. So and so that we have further examined the patient. Then patient was even having neck stiffness, and there was with the Brodinski sign was and Kernick signs was positive.
If you got this patient again, would you have done something differently in your initial management?
Yes, ma'am. If we have seen this, we should we should initiate the antibiotics as early as possible. Yeah. Then we will get the CT done to rule out any hemorrhage or any bleeding, any infarct or any bleed, or to look for any mass lesions. Then we will plan for if there is any significant no bleed and no hemorrhage, then we can plan for LP to look for any CSF culture analysis purpose, we will perform the lumbar analysis, lumbar puncture.
So what you're trying to say is the order should have been neuro first, dialysis could have happened next, right? When
And
you
in our first differential only, we should have suspected like meningoencephalitis. Like
may
initially,
or
we
may not suspect, but that's more time dependent, right? So if there is a second diagnosis also, if it's not even the primary diagnosis, the dialysis can happen after you've taken steps for the meningoencephalitis. That's an emergency. If it's encephalitis, you have to first rule it out. When you do a CT scan before an LP, what are you looking at?
mainly like
Conditions,
You will
ma'am.
not do an LP. If there is a bleed, you will not do an LP.
we have to see for like raised ICP features, ma'am. Like we have to roll out that like raised ICP or any new onset of seizures coming with a
In CT scan, what are you looking at in CT scan?
like basal systems, ma'am,
For
for
meningitis, ma'am, you are asking? Or
No. Before you do an LP, you just said, I will do a CT scan and then I'll do an LP.
like we have to see for any mass lesions, ma'am, like any space occupying lesions.
lesions?
Why
Or
is
raised hydrocephalus, raised ICP conditions, we should rule out now, because to prevent coning of the drain
Like, we
parenchyma
have to
structures before inserting the needle. Before
meningoencephalitis itself can cause raised ICP. So why do you do LP there? So I'm just looking at a particular answer.
like we can do for like therapeutic, we can go, ma'am, LP in.
So it's a global rise in ICP will not really cause a coning. It's a unilateral, when you said space occupying lesion or a bleed on one side, then it can cause a unilateral coning. So it's not, many people think that the bleed, we can't do an LP. So it is not really that. It's a space occupying lesion raised in ICP, unilateral, which can lead to coning. Because you don't do an ICP measurement before you do an LP if there is no other lesion, isn't it?
Yes.
And even then, now, if you see the recent guidelines, there is a movement towards you rule out certain things and you can still do it with a fine needle and everything. Patient is comfortable, it can still be done in the hand of experts. Okay. Go on.
Standard question they're going to ask, like she said, is no patient, this is mandatory to do an LP, CT scan everybody before LP? What is the downside of doing a CT scan before LP? What is the disadvantage of doing a CT scan before LP?
disadvantage.
Like we'll be missing our precious time now. So, like we should not delay.
Delayed. So which patients can you probably afford not to do a CT scan? In suspected meningitis, in which patients can you afford not to do a CT scan before proceeding with an LP? And everybody don't have to do a CT scan.
Like any patient who is immunocompromised, we are seeing, or
You
any.
have to do an LP, no, non-immunocompromised. So I'm saying in these patients, you need not do a CT scan. So non-immunocompromised. Immunocompromised, mandatory to do an LP.
Examination also. In this patient examination, you said.
So no papilledema, no immunocompromised,
No.
what else? No seizures.
No seizures. And no, there is no
not true for
GCS.
mental status, age less than 60, okay? Age
No,
less than 60, not GCS reasonable, no immunocompromised,
focal
no
neurological
seizures,
deficit.
no focal deficit, okay? There you probably can, like you said, get away with a guarded LP. Others you have to do a CT and then proceed with. So you understand, because you don't want to waste time, but sometimes you have to do it.
Next slide.
And the neck stiffness always there in meningitis? With absence of neck stiffness, rule out meningitis?
No, sir.
CT. I
Which
didn't
patients generally do not have neck stiffness? Which group of patients?
Next, in encephalitis picture, there is no need of
meningitis. Forget about meningitis. That way, malaria also will not have any. I'm talking about patients meningitis that don't have neck stiffness.
Not like everybody should.
Immunocompromised may not have neck stiffness. They don't have to have even fever. Okay.
Yeah.
So neck stiffness is not mandatory. Okay. Any elderly patient with altered sensorium, meningitis is always a possibility. So you will have to think of meningitis.
So neurology review was taken and advice for lumbar puncture and MRI brain was advised. So suspecting meningoencephalitis, like we have initiated on ceftriaxone 2 grams BD and vancomycin 1 gram TID. And injection dexamethasone 0.15 mg per kg QID dose. And patient underwent LP in ICU and CSF samples were sent for analysis.
Anything else you would have given this patient? How old is the patient?
57 years male patient, sir. We can
57-year-old
give
patient coming with convulsions, fever, suspecting some meningoencephalitis. Anything else you think the treatment is adequate or something else should have been given?
yes, ampicillin, because of more than 50 years, we should have added ampicillin 2 grams fourth hourly. And
what?
as
Listeria, sir.
for listeria.
Which other group of patients, adults are talking, need ampicillin other than post 50?
Pediatric age group, sir, like
Pediatric.
less than 3
adults. Which other adults?
Immunocompromised patients.
Immunocompromised. And which other group? Non-immunocompromised adults, less than 50. In fact, younger patients. Pregnancy. Pregnancy, immunocompromised and above 50. Okay. Any other drug you would give? Somebody with convulsions and
Acyclovir antivirals also we will start, sir.
Which one?
Acyclovir 10 mg per kg body weight.
Ideally, you should be giving acyclovir because of convulsions and all that. So at least till you get everything back, you should be sent. And why do you give vancomycin? Why not only ceftriaxone?
To cover the cephalosporin resistant pneumococcus, we initiate vancomycin, sir.
Yeah, for resistant pneumococcus. Okay.
Next. So CSF analysis was done, which was showing proteins of 750, sugars were 96, TLC was.
Sorry, may I interrupt? About steroids, dexamethasone was given. Why is it given dexamethasone? Do you think dexamethasone was useful in this patient? Or?
Yes, we should give, sir, for as empirical therapy. We will start the dexamethasone.
What is the recommendation for steroids in meningitis? In adult meningitis.
So can you repeat the question, sir? I'm not able to.
No, what is the recommendation for the use of dexamethasone in adult bacterial meningitis?
Sir,
the recommendation. What do the guidelines say?
Yes. Why we give steroids is when we give antibiotics, it will cause lysis of the bacteria, which cause severe inflammation.
When should you give the steroids? Exactly. So when should you be giving the steroids?
It should be given before antibiotic initiation, sir.
And if somebody has already got an antibiotic, like this patient already has received cephalosporin Selbactam.
Yes, sir. But
so within how much time can you give steroids?
Like ideally, we have to give before.
Given before or with the first dose of antibiotics.
With the first dose of antibiotics.
Now, in patients like this who already received antibiotics, is there any point in giving steroids, or you don't give steroids?
Actually,
like we have to.
Recommendation says within 4 hours. So theoretically, this patient after 4 hours, there is no point in giving steroids because he already received cephalosporin Selbactam the day before only, I think, no? Or after,
yes.
Before 4 hours.
I mean, 4 hours.
You can give it before the first dose, but if for some reason you receive antibiotics, within 4 hours of the antibiotics, you can still continue steroids. Beyond that, debatable, okay? Yes. And even for the bacteria, if it is not pneumococcal, some people say don't give, but at the moment, I think most recommendations say whatever the bug you give. But ideally should be given before or with the first dose of antibiotics, and ideally within, if not, that's not possible, within 4 hours of the first dose of antibiotics. Fine, go ahead.
So proteins were 750, sugars were 96, and TLC was 80. In that, neutrophils were 70%, lymphocytes were 30%, ADA was 9.7, gram stain, there was no AFB, cultures were sent, which was awaited, gene expert was negative.
Simultaneous sugars at the time of lumbar puncture was 400 milligrams per deciliter.
That should have been mentioned.
Next.
And even MRI brain with contrast was done, which was showing leptomeningeal enhancement with ependymitis with mild acute hydrocephalus and flare hyperintensities in the bilateral occipital horns of lateral ventricle and with reduced ADC. and diffuse pachymeningeal thickening and enhancement in left frontal convexity and falx cerebri. And even CSF PACR panel was also sent, which came to be negative.
How does MRI add on to CT scan findings in meningoencephalitis?
Like if we are any stroke or anything, we can rule out, ma'am.
Any more?
Um, is stroke commonly seen with meningoencephalitis? When you say stroke, what exactly are you referring to?
Like infarct, ma'am.
And any brain mass lesions and
We're talking about meningoencephalitis now.
leptomeningeal enhancement can be better seen in
You have that CSF report. It's clearly meningoencephalitis.
And
Will it
like
add on to this?
mainly in TB, like in TB meningitis, we will see infarcts, ma'am, in the temporal region. So that
Why in TB you would expect, like if you see an infarct, you might think TB, why? More than others, more than any other bacteria or viral. What exactly is it in TB meningitis that you're looking? Whenever you send an investigation, you must know why you're sending it.
yes.
If it comes back and I see this, I will think this. I don't see this.
ADO levels was around borderline, ma'am, which was 9 in our CSF values. So we have a query to see for any basal exudates. Is there any other thing? So already in CT it was showing like hydrocephalus was there, which was also one of the complication of bacterial versus and the TB meningitis. So we want to confirm whether any basal exudates or any leptomeningeal enhancement in MRI. So we perform to.
It is severe vasculitis in TB
In,
meningitis,
in TB meningitis.
which is one of the reasons why you see more infarcts. And you said correctly, hydrocephalus. Okay.
Next.
And viral meningitis, would you see something specific?
Yes, in viral meningitis, temporal lobe hyperintensity is suggestive of HSV simplex virus, viral encephalitis. And if it is limbic thalamic encephalitis, means most commonly seen in autoimmune encephalitis picture.
And in Japanese encephalitis also, it will be involving the brainstem and thalamus.
Thalamic picture.
So which in HSV, what is paired? Which part of the brainstem is paired in HSV? You're right, temporal and frontal lobe are affected.
Temporal lobe.
Basal ganglia are generally spared. The basal ganglia is affected, like you said, it's more likely to be your Japanese encephalitis. So basal ganglia generally spared with the HSV, okay? Temporal lobe definitely is classic of HSV, but
Classic for HSV.
And if any autoimmune we are suspecting, then there will be hippocampal hyperintensities.
and for TB, what other tests would you do? Suppose you're suspecting TB meningitis. Now your CSF, you said ADA was, what is the cutoff for ADA?
In our reports, it was 5,
Five, ma'am.
so more than 5.
Slightly high. Okay, it's not foolproof, but ADA, is it a
No,
foolproof test for meningitis?
No, sir.
Not
no.
a 100% sensitivity or specific. Sensitive it is, but specific no. So
we
here
have-
gene expert was negative.
Yes,
Now
sir.
what else can you do?
We have sent even the
Please,
blood
sir.
for culture also,
Any
sir.
other gene expert is there now for meningitis? What is the latest gene expert for meningitis? It's called Gene Expert Ultra. Okay, it's more sensitive than Gene Expert. So probably nowadays, if you suspect TB meningitis, your multiplex PCR will not pick it up, but you can do a Gene Expert Ultra. Okay, slightly better than Gene Expert for meningitis, especially for meningitis. What else can you do when you suspect meningitis? So TB meningitis, since you don't have definite diagnosis, what else can you do to make the suspicion of TB stronger?
Cultures, sir. One thing we
You're going to send culture, but culture is going to take time, no? And you have to treat it quickly. No? You can't.
PCR panel we have sent, sir.
That I said, multiplex panel doesn't contain TB. You're doing a Gene Expert Ultra. That's a PCR, no? ADA you have done. You can also do a CT, chest, abdomen, etc. Because sometimes they may have TB elsewhere in the body, which might make the suspicion of TB stronger. Okay, so since you want a definite diagnosis and you're not sure, so there maybe, because you don't want, I mean, obviously, you don't want to miss TB at the same time, you don't want to overtreat or you don't want to miss other diagnoses, but You want to make a suspicion stronger. So these are the things you can do, okay? You can do a CT of the rest of the body because sometimes you might pick up something in the lung or abdomen, which makes this of TB stronger.
Next. So this was our meningoencephalitis panel, which was negative for all the virus and bacteria and even fungus element.
Which fungus in meningitis?
Cryptococcal.
So what is the best test for cryptococcal? Is it the PCR or anything else?
Antigens of cryptococcal
antigen. We have sent that.
Happen in immunocompetent people, or it does happen only in immunocompromised?
Most commonly in immunocompromised, high risk for immunocompromised people.
But is it necessary to do a cryptococcal antigen in every patient, even immunocompetent people, or you wouldn't do it in immunocompetent people? In a patient with meningitis who is not immunocompromised, is it necessary to do a routine cryptococcal antigen? No, you can have cryptococcal gatti affecting the immunocompetent persons, okay? Cryptococcus neoformans affects immunocompromised, especially HIV. Cryptococcus can also affect immunocompetent people. So, and cryptococcal antigen is not a very expensive test and a very reliable test. So, it is better to do it routinely. Quite often, you mistake TB, you mistake cryptococcal for TB, and even in immunocompetent people. So, as a routine, it is better to do a cryptococcal antigen in every patient with meningitis, immunocompetent or not. Okay? Because it's a very treatable condition. If you miss cryptococcal, your PCR is there. This multiplex PCR is there, but sometimes it may miss cryptococcal. So better to do cryptococcal antigen in everybody.
Next. So subsequently on the day 2, patient's sensorium had worsened. GCS was dropped till E2, V2, M3 to 4, and breathing was also shallow. So in view of maintenance of the airway, we have electively intubated the patient and kept on mechanical ventilation. Subsequently, patient had mild shock and fever spike was present.
The patient with seizures on mechanical ventilation, what can cause most precipitate further seizures?
Like
suppose you keep the rate high, low, what will cause more seizures? High rate or low rate?
Like we have to keep normocapnia, sir, here, because we should avoid hypercapnia and even hypocapnia.
Which is more likely to cause seizures?
Like hypocapnia, it further.
Why hypocapnia? Why will it cause seizures?
It further decreases the perfusion, sir. Like it can cause. Hypocapnia causes.
It will cause seizures, I'm saying.
Seizure mainly hypercapnia. It might elevate more.
I'm saying hypocapnia causes seizures. Why does hypocapnia cause seizures? Should avoid hypocapnia. What acid-base abdominal hypocapnia cause?
Like hypocapnia.
Causes what acid-base abnormality?
CO2 levels will be.
What acid-base abnormality does it cause?
Metabolic.
Metabolic.
Respiratory alkalosis.
Respiratory alkalosis. What is alkalosis due to seizures? What does it do to the seizure threshold?
It will decrease.
Yeah, decrease seizure threshold, no? Also, calcium can come down because of alkalosis. Both, even in any case, one is of course hypercalcemia fluid. In any case, alkalosis reduces the seizure threshold. So you try and avoid alkalosis in these people, okay? Metabolic or respiratory or whatever, but so you don't overventilate them. Make sure that they are.
Next slide. So again, neurology opinion was taken for MRI brain, and after multidisciplinary discussion, even like neurologists and we like suspecting TB meningitis with hydrocephalus. So in view of worsening sensorium, also we had to initiate on antitubercular therapy. So we have, for that reason, we have initiated on anti-ATT, and even we have increased the dose of dexamethasone for 0.4 mg per kg per day, and subsequently our blood cultures which we have sent it grew Enterococcus faecalis, which was sensitive to vancomycin. So we are continuing vancomycin.
This was on day 1. The blood culture sent on day 1.
Yes, sir.
Day 0, day 1.
There's a question in the question and answer panel about the duration of steroids for these patients. How long would you give steroids?
So normally 4 to 8 weeks in if you are suspecting TB meningitis, tapering dose has to be started. Initially, we have to start with 0.4 mg per kg. Subsequently, the next week 0.3 mg per kg. Subsequently, the third week 0.2, and then fourth week 0.1. And tapering doses for
Oral doses should be tapered for next 4 weeks, ma'am. Similarly, like 4 mg for 4 mg per kg on like 5th week, the 3 mg per kg for 6th week, and subsequently to for the total duration of 8 weeks we will give.
If it
What
was
about bacterial meningitis? How many days of steroids?
For bacterial.
for other types of meningitis, bacterial,
But
viral,
some other types of meningitis, it will give of 0.15 mg per kg dexamethasone QID dose for following 4 days, ma'am.
4?
4 days, 4 more days.
Fine.
viral,
Viral we don't give, ma'am, actually. It only we indicated in streptococcus and influenza in some cases, ma'am, actually. These two were the main indications for it. And other things, there was no substantial evidence for giving the steroids.
So it's there for bacterial meningitis. Now they say whether it's pneumococcus or not, you can give steroids, except which bacteria you don't give. It's contraindicated. Listeria, okay? Listeria, it's contraindicated. Most benefit is H influenza in children and pneumococcus in adults, but they give for all bacterial meningitis except for listeria. If you find out it is listeria, you stop the steroids. Which of the TB medications penetrate the CSF, have good levels in the brain?
like pyrazinamide, isoniazid, and rifampicin.
Which else?
Rifampicin
No,
does
I'm not what else? Which other TB medications have good levels? Only these 3. It could be any first line, second line, any TB medication. I'm just talking which TB medication.
isoniazid and pyrazinamide
That he said. Isoniazid, pyrazinamide, rifampicin. Ethimetol obviously doesn't have.
doesn't.
So which other drugs TB medications have? If in desperate situations, you would like to give as many drugs that reach good levels in the brain. No? So which other drugs can you try?
Second-line drugs like amic acid.
Amic acid doesn't have it. So name some other second line TB drugs, no?
Amic acid, ethionamide, cyclosarin
Does cyclosarin have good levels in the brain? Nowadays, of course, everything has changed for second. Quinolones, quinolones quite often people use ethambutol. Okay,
in TB meningitis,
What's the problem
moxifloxacin.
with using quinolones in this patient?
Moxifloxacin we can give.
What is the problem? What is the potential danger of using quinolones?
They decrease the seizure threshold.
Threshold will be decreased.
Seizures. Okay, so which of the quinolones is safest on the seizure point? Which is the most dangerous? Which is the most likely to cause seizures? You know, Cipro is the most likely, and which is the least likely?
Levofloxacin.
Probably levoflox. Yes. So the other drugs that reach the brain are cyclosarin, ethionamide, linezolid. Okay. Nowadays, of course, secondary drugs are the whole thing has changed with all these newer drugs, but at least quinolones quite often people add because because ethambutol doesn't have good penetration, so they would like to give at least 4 drugs with good penetration. And most people probably, suspecting TB, would add quinolone, probably levofloxacin. But why do you think this enterococcus didn't cause a meningitis in the first place?
But day 4 we got the blood cultures, so it can be like bacterial meningitis can also be chances along with tuberculosis.
No, but his lymphocyte cell count was low, na? So can there be a bacterial meningitis?
Actually, because it was we have initiated antibiotic cells, so it could be like partially treated.
Difficult to say, but
Would you have got it on the multiplex PCR you sent?
Multiplex in that it has not picked anything.
Negative for TB also, I mean, tuberculosis also it was
So
negative.
would you have got Enterococcus fecalis in that panel?
No, ma'am.
You would not. That's the point.
it's not the common, so it's not on the panel, no? It's not there on the panel. You don't know. It's not the common organism, but it's not impossible to get. And for Enterococcus fecalis, is vancomycin the drug of choice?
It was sensitive.
We can even gentamicin.
Gentamicin. No, you have to look at the sensitivity, but quite often Enterococcus
sensitivity,
fecalis
vancomycin
is
sensitive.
like ampicillin or coamoxiclav or piptazo. I'm not sure anyway.
But this Enterococcus fecalis was sensitive to vancomycin.
Maybe sensitive to vanco, but it should be sensitive to something lesser also, no? I'm not saying if it's sensitive to vanco, you have to use the highest drug or you don't use vancomycin. If it is sensitive, you use something lower, no? You don't use. If it is also sensitive to piptazo, between piptazo and vanco, you use piptazo, you use vanco. You prefer to use the lowest drug, no? Lower drug,
Yes.
drug, no? And the least toxic drug, no? You wouldn't prefer to use the more toxic drug. And suppose something is sensitive to meropenem and ampicillin, you'd use ampicillin or meropenem? You'd use ampicillin, no?
Ampicillin we will use.
That's what same. So you always use the lowest drug in the least toxic drug, no? Not the lowest spectrum, no? Rather than the broad spectrum drug. Maybe sensitive to many things, but you use the lowest. What complications occur in TB meningitis?
Mainly we see hydrocephalus, sir, like seizures, and there will be like ventriculitis or cerebritis or brain any abscess.
Abscess
And
TB is less likely. Okay, you said ventriculitis, you said hydrocephalus. What else can happen?
like infarct also we can see vasculitis, infarcts.
So anything can be done to prevent this vasculitis?
Normally like steroids will be helpful for
Steroids, of course, but some people recommend aspirin also in TB meningitis. Okay, aspirin also. So steroids, aspirin, AKT.
Next. So subsequently patient sensorium was slightly improved. So but irritability is still present. So like we are planning to wean from ventilator. So this patient is still with
In
us
our ICU.
in our ICU. Ongoing treatment is going on.
Yeah, we don't have a definite diagnosis, but all's well that.
So how quickly the patient improved? TB meningitis really won't improve that quickly, isn't it? When you say improved, and irritability means GCS is
Yeah,
30.
still.
E4, ma'am.
But
E4,
he was drowsy and his sensorium was not that good. Bulky, we have intubated him. But subsequently he's slightly alert. Alertness is there, but irritability is main concern right now. He's more
So
irritable.
it's a span of less than 7 days?
Yeah, less than 7 days.
It's day 9.
That kind of then points towards what Dr. Ashith was saying, that it's probably a bacterial enterococcal infection, because which has incidentally been managed with the vancomycin which you were giving for the bacteria. Anyway, trying to cover, because otherwise it wouldn't be such a rapid improvement, only with TB meningitis. There was a question here. I think this is more about imaging. I'll take two of them together. What is there's a question about status of cerebral vessels. Did you image the vessels or did you find it? Any comments on your imaging about status of vessels?
Yeah, actually.
Was it anything significant? I don't think there would be, because there was no stroke and no other sequelae of vasculitis.
MR was done, which was not significant.
Right. And would there be a role for transcranial Doppler being performed when you noticed a dip in sensorium? This is another question. I'm putting it to you.
Yeah, like
Yes, ma'am.
we can see like
Raised IP intracranial pressure can be assessed, ma'am. When the dip in sensorium, we can suspect of raised ICP can be possibility, so that can be seen.
like any MCA velocities are high, so like any spasm or any because of raised ICP, we can see that more.
You may answer the details of how to, it may be outside the scope, but how to, maybe Likhitha, you may be asked how you will assess ICP with transcranial Doppler and how useful it is in a medical ICU. Okay. So
Like in subarachnoid hemorrhage, they are more
we know
useful.
about subarachnoid hemorrhage, but your MRI now doesn't show anything. So in this picture, will TCD help and how it will help? You'll also be asked about optic nerve sheath diameter. Could you have used that?
Yes,
Yes.
once I have done by placing the probe on the eye, by proper closing of the eye, applying the gel, and by placing the probe on the eye, we can see the globe. We should measure the 3 mm away from the optic nerve starting and keep the perpendicular line to that, and we should measure the diameter between the inner diameter we should measure, ma'am. We
So
should see bilateral.
you're
both.
right. You're correct. If you have an ultrasound and you have a TCD enabled ultrasound, just to see that there is a rise in ICP, which method you would use? The TCD or the ONSD?
ONSD, I have used ONSD, ma'am, but in our in our thing, the TCD was not there, so I didn't use such.
Good answer. First, you say my experience is better with ONSD. Second, TCD is very user dependent. You may say something, the next person will say something else. It's probably not ideal in this situation. So if you just want to see whether there has been a change in rise ICP, you will do a TCD and you will get an idea of what's happening inside.
Like if we do sequential, then we will be able to know. Like before, how was it, and now.
Sequential in which?
Like in ONSD also, ma'am. Like
Sequential ONSD is not very helpful. If it's rising, you will know. But if you give something and your ICP, you want to see if it's coming down, ONSD is not going to be very helpful. But vasospasm, sequential changes, TCD is better. But one shot, like it was okay today morning rounds, there was ICP was all right. Today, the sensorium has dropped suddenly, and you do an ONSD, and the pupillary size has changed from 4.5 to 6.5, you are sure it is raised ICP. So ruling in is good.
yeah.
And it's easy, it's bedside, it's available, not as user dependent as TCD. Okay.
Yes.
Anything, sir?
I think we have covered it, no? Do we
Yeah,
have time?
Yes, sir. We have fairly covered, sir. So one or two questions, sir. Regularly, that's what is generally come across in ICUs. Like the role of CSF lactate, sir, at the bedside to differentiate between bacterial versus the viral meningitis. How you helpful, sir, your experience?
Theoretically, yes, lactate normal, it's supposed to be helpful, aseptic versus septic meningitis, lactate levels being, but generally, I think we go more by clinical features. Sometimes these people generally are much milder illnesses. And, it's very difficult in a meningitis not to give, but if you're very sure the patient is not that sick and generally has a preceding something like a viral, like a diarrhea, etc., there maybe you might consider that this might be viral, provided the patient is not too sick. In those situations, sometimes we don't give antibiotics, especially the lactate levels are normal, and repeat the LP after a couple of days. But obviously, you need to watch the patient closely, because if they're going down, there's no question. But if they're all okay and you don't give antibiotics, repeat the LP in 2 days, if the LP is improved, then you know it's definitely viral. But yeah, so in that situation, what we use lactate otherwise is for nosocomial meningitis, especially in patients with an EVD. It is supposed, because if somebody's already had neurosurgery, quite often the CSF is going to show cells and proteins and all that. So there also maybe a lactate level might help you separate a nosocomial from just a post-durectomy syndrome or whatever else. But again, in the setting of subarachnoid hemorrhage, which is the commonest reason for putting an EVD, they say the RBCs in the CSF consume lactate. So there the lactate levels may be falsely low. So it will not be reliable if there is blood in the CSF. Otherwise, lactate is okay. For we use it more for nosocomial versus just a reaction to surgery.
Reaction to chemical meningitis versus
Yeah,
nosocomial.
any dura that's open, you get a chemical, you get a reaction. So
Yes,
I think Swagata must be used. I don't know. You see more neurosurgery and all that.
Yes, sir. We do it much more often in the neurosurgical post-op patients, like you said, to differentiate.
So the repeating LP, in what instances generally you think? So generally, we generally don't very regularly
No,
practice.
one is if there is definitely, they're not sure it's meningeal, like you said, viral or bacterial, and you're not given antibiotics. That's one. And two is if it's a resistant meningitis and the patient not getting better in 48 hours, definitely repeat the LP. 48 hours not getting better, no question, you have to repeat the LP.
Repeat the LP. So probably you suspect the resistant pathogen might be there. You hike up and
So you have to
antibiotic.
document improvement. If there's no improvement, you have to see why it's not improving. Either change your antibiotic, make sure your levels are high, whatever. But if the patient is getting better, you need not repeat the LP, no question. But the patient not getting better, 48 hours, you have to repeat the LP.
Yes, yes. Madam, Swagata, madam, what do you think is the role of intrathecal versus intraventricular? Suppose if there is a drain and all, the role of antibiotics, community acquired, we don't generally regularly use. We generally use nosocomial. What do you think is the role, ma'am? What is your opinion on that?
Community acquired, no. I mean, it won't be necessary, isn't it? It's only when you have no other option and the drugs that are available won't cross the dura well, you need to think about giving a colistin. Then we do occasionally, mainly only for colistin, we've done it really. If there is a drain, very good in the ICUs, surgical ICUs, the EVD we do use in intraventricular. And half a dozen times also intrathecal injections have been given along with intravascular. So IV plus intrathecal both.
Yeah, the says a penetration sometimes would be better. That's the intention of doing it. So, madam, yeah, like final comments, I think we have discussed much this thing. From Swagata, madam, what do you think, like the tips to the students while giving Viva in their exams and practical exams?
I think both of you presented very well. My only suggestion would be that think of what the examiner is thinking, and take them towards your diagnosis. So when you're presenting the positive and negative features, you should just help them mentally tick it off. Like there was no history of any eating disorder, sodium was okay, no alcohol. If you keep saying that, there is no other place the examiner can go. So lead your discussions towards your diagnosis. It just makes it easier for you. So kind of it's a trick for your exams. You don't have to say it like it happened. I know you were trying to say exactly what happened, but I don't know what happened. You can lead me towards what you want me to think. That's very helpful for your exams. And I was just, for this thing only, I was looking at two recent papers, one in intensive care medicine, which is very short and succinct, and it just tells you the recent evidence base for what is being done. All that we discussed, a lot of it, Dr. Ashith told today very nicely, where steroids, what about viral, and what about autoimmune encephalitis and meningitis. So have a look at that. It's quite recent, I think, August 2024 in intensive care medicine. Have a read at that. And there is one synopsis in Indian Journal of Critical Care Medicine from Dr. Himanshu Parwata, I think, or Dr. Harsh Satra for Indian meningitis in Indian ICUs. So both of them are nice. Have a look at that. That's all from my side, but well done.
Thank you.
Final comments from you, sir, Dr. Ashith, sir. I think 2-3 points I learned from you is one, Gene Expert Ultra, I think, and cryptococcal antigen testing. Both are very good points. Even I learned those 2 points today.
Yeah, good microbiology we learn from them, but yeah, I think very well. I think our main strength is the microbiology, not the physicians. But so,
yes, final comments from you, sir.
I think the lady should always be final words. So I think that's
Okay, sir. So, sir,
No, they're okay. But like you said, basically, I think most people try and think that we want something special. I think you should just say what you're doing routinely. Most of us are practicing, I think, reasonably, decent medicine, not practicing something that is out of the way. So you just do tell them what you're doing. We're not looking for any exotic answers. We're just looking for what you're doing in practice. That's it. Don't think there's some hidden agenda or we're asking some, really tough answer. We just want you to know what you're doing every day. That's all. So just say what you're doing. That's all every day. Unless you've been taught the wrong things, then I can't help you. But otherwise, if you've been doing the right things in your ICU, there's no problem.
just tell it out boldly. Yeah. Yes, sir. Thank you very much, sir. Thank you very much, Dr. Ashith Hegde, sir, and thank you very much, Dr. Swagata Tripathy, ma'am, for coming onto our platform and sharing your clinical insight and practical knowledge. Definitely very helpful. And thank you very much, Dr. Imran and Dr. Likhitha, for both of them presenting, taking out that case from your ICU and presenting on this platform where I think most of the students and clinicians get benefit out of this. And thank you, our Yashoda Hospitals and digital team and branding team for regularly providing this platform to conduct these classes. And thank you, our audience who are regularly tuning into our webinars for this. And thank you very much. And, good night, sir. Yeah.
Good night. Good night.
Thank you.